growing field of oncology looking at radioligand therapy, or PRRT, and it's moving very fast. It started in neuroendocrine cancer, but certainly what we are seeing is that it continues to be growing in other areas as well, and therefore wanted to give an update on where we are, at least in the neuroendocrine world, on this. These are my disclosures. And my other important disclosure is, of course, I'm viewing this from the point of view of a medical oncologist. And if we talk to Sten and we talk to our radiation colleagues and we talk to our nuclear medicine colleagues, they are also involved in this treatment and important partners. But certainly, we also recognize that they may have different perspectives. What's interesting about radioligand therapy is that traditionally we've always thought about cancer therapy as systemic therapy, radiation therapy, and surgical therapy. But this really covers a number of the different sites and transcends some of the previous silos that we've had. Objectives today is we're going to try to review what exactly is radioligand therapy and what's its role in neuroendocrine tumors. Want to give you a little bit of an update on some new data that's come out just in a few weeks ago. Not in presentation mode. I'm just seeing. Hold on. I think we have a problem with the slides. Let me try to see if I can correct this. Is that better in terms of the slides? Okay, hopefully that's okay, and please let me know if that's not the case. Okay, thank you so much. Thanks for alerting me to that. Okay, so the goals today are to review the role of radioligand therapy in neuroendocrine cancers, to look at the latest clinical data. We've had some new updates recently in the last couple of weeks, to discuss often the clinical benefit and toxicity like we do for any treatment, but especially with radioligand therapy. And I also want to discuss some opportunities, as well as just let people know a very general overview of the new clinical trials we have, because we certainly have a number of new clinical trials that are that we are starting on neuroendocrine cancer and radioligand therapy. So I just wanted to share this data. This is data that Julie and I have been working on, Julie Hille and I have been working on, and it's very brand new. It's unpublished, just from last week. But I wanted to show you the importance of the need for new treatments for this type of cancer. This looks at our incidence in Ontario from 2000 to 2023 of neuroendocrine neoplasms. As you can see, there's been a dramatic rise, along with a dip during COVID, like we saw in many cancers. But this brand new data shows that the incidence of rise of neuroendocrine cancer still continues. And this is also similar to what we're seeing in the United States. I wouldn't say that this means we suddenly have a new, epidemic of neuroendocrine cancers, but probably there's been out there, and we recognize them, classify them, and have organized them much more than before. And when it comes to prevalence, it's the second most common GI cancer. So it's important that we want to make sure that we are treating these cancers with the new treatments as much as possible. When we look at the different types of neuroendocrine cancers from this new data, it continues to be the small bowel, the rectum, and the pancreas that are predominantly some of the major players here. So really, it's the GI tract where we see many of the neuroendocrine cancers, but lung neuroendocrine cancers, which isn't shown here, also plays a role. So I'm going to talk to you as an update about where radioligand therapy sits in lung neuroendocrine cancers as well. So what is PRRT, or radioligand therapy? This is still a newer treatment, so I think it's still worthwhile reviewing this quickly so that we are all on the same page. As you can see here, we have these radioisotopes that are they can be therapeutic or they can be diagnostic. We can bind these decaying isotopes to a target ligand, in this case, dotatate, and then this little compound can bind to receptors on the surface of the cancer cell. In this case, it's going to be SSTR2 receptors. And the reason that this therapy has been so successful in neuroendocrine cancers to date and continues to be an area of growth is because the SSTR receptors are nicely defined on neuroendocrine cancers. And we want to ensure that when we are treating patients with these treatments, that we see that there's SSTR2 expression, because if you don't have SSTR2 expression, then this treatment isn't going to work. So how does this look like? Well, you have this compound of a radioactive substance and the somatostatin analog. This then binds to the surface receptors to the cell, like we talked about the SSTR2. It then gets uptaken by the cell and internalized, and then the radioactive isotopes slowly decay. And And that slow decay over the next 6 to 8 weeks causes cellular damage, hopefully preserving normal tissue as much as possible. And so this is, again, a way of, depending how you look at it, delivering systemic radiation therapy or systemic radiation isotopes. Now, again, where did we come from? Where did this treatment come from and how has it been developed? And the reason I bring this up is that it's taken a fairly unique pathway from where we would normally think of drug development in many of our other cancers. So this was a paper in JCO that looked at the Rotterdam experience from the Netherlands. And as many of you are aware, this is highly uncommon for JCO to publish a retrospective series. But, there was promise of this treatment well before it came to market as a commercial product. This was being done at numerous centers as sort of experimental therapy. And one of the large centers was Rotterdam, where they had a history in this 6-year period. And they looked back at 504 patients who had over 1,700 treatments. Efficacy was assessed in 310 of the 504 patients. Now, these are patients coming in for referral, for experimental therapy, and therefore they probably lost track of some of the patients. What they saw was a CR rate of 2% and a PR rate of 28%. This was generally in treatment refractory patients who were being treated. The minor treatment response, which they defined as up to 10%, was 16%. And in this very heterogeneous cohort, and I can't emphasize enough how heterogeneous it was, their median PFS was 40 months and the overall survival was 128 months. So these patients who had generally tried a number of previous treatments, as you can see, all continue to have stable disease after this, or a good proportion of them. When we look at the group of patients that they looked at, it was a fairly heterogeneous group of patients, but I should mention that there was either moderate to extensive tumor mass at baseline in most of the patients, and most of them had moderate to extensive liver involvement as well. So a fairly, again, end stage, more treatment refractory population. In their retrospective analysis, they showed about 3.6% of grade 3/4 hematological toxicity. Interestingly, one of the major side effects that we know about with radioligand therapy and neuroendocrine tumors is myelodysplastic syndrome. And we're going to talk about that in just a second. On their series, they only showed 4 patients, less than 1%. So that is very low, actually, compared to what we see. So again, you have to wonder about if we're monitoring this correctly. They had some non-fatal liver toxicities, some renal toxicities, but they did have a high rate of nausea and emesis. And one thing, again, to mention about radioligand therapy is to protect the kidneys, we give concurrent amino acids. Those amino acids can be highly hematogenic. So often it's a different type of hematogenicity that we see as compared to systemic therapy, which we traditionally think of, which lasts multiple days, and we want to give multiple days of therapy. You want to give a prepitant, etc. Here, it's really the amino acids. And as we either improve the amino acid composition, which we see much lower rates of nausea and vomiting now, but also when you stop the amino acids, the nausea almost dissipates completely. So again, a very different model of some of the common toxicities than we would think of in traditional systemic therapy. We then moved to the randomized area of PRRT, and this was a new time when we started to see proper randomized oncology trials to look at this therapy, and this has resulted in a what I would call an explosive growth in the use of radioligand therapy, first in neuroendocrine tumors, now in prostate, but also moving into many other areas. So this was the NETTER-1 trial. The NETTER-1 trial looked at patients with small bowel neuroendocrine cancer. They had to have progressed on somatostatin analogs, which were and remain to be our bedrock of treatment in terms of neuroendocrine cancers. We often start patients who have SSTR receptors with somatostatin analogs. We know that somatostatin analogs are cytostatic and not cytocidal. So often these patients are going to continue to grow after some period of time of stability. And this is where NETTER-1 looked at a randomized trial of lutetium dotatate versus high-dose octreotide. I'm hoping most of you are aware of this study because this is really the first randomized study in radioligand therapy and resulted in approval of Lutathera for treatment. It was a fairly positive trial in that the median PFS in the Lutathera arm was 28.4 months versus 8.5 months in the high-dose octreotide arm, or hazard ratio of 0.21. And I think we can all agree that when we start to see hazard ratios of 0.21 when we're looking at oncological treatment, that is fairly promising. We then start to think about the objective response rate, and the objective response rate in the Lutathera arm was 18%. Again, not dramatically high, but when you think of neuroendocrine cancers, up to this point, we had really been treating these cancers with cytostatic agents, and so response rates were very low. So the fact that we're starting to see some response and some shrinkage of disease is very promising, especially when we start to think about the long-term outlook. Are we able to potentially open up a surgical window with perioperative or neoadjuvant therapy? For patients who are secreting hormone, are we able to shrink the disease and potentially improve their hormonal secretion as well? I haven't shown it here, but there actually was an improvement in quality of life with Lutathera in the NETTER-1 trial with a time to deterioration. And so this started to really open the doors to maybe radioligand therapy can be more destructive to the tumor than we'd originally thought. This led to a second trial, which we were fortunate to be able to lead here out of Sunnybrook, and this is called the NETTER-2 trial. And this looked at 177 lutetium dotatate, or Lutathera, who were in newly diagnosed patients with a bit of a higher grade patients, grade 2 and grade 3. This looked at patients who had gastroenteropancreatic neuroendocrine tumors, so of the GI tract. They had to be newly diagnosed, they had to be more aggressive, and they had to really be treatment naive. Now, why was this trial done? Well, we need to go back and start to think about the different types of neuroendocrine cancers. So when we talk about neuroendocrine neoplasms, we divide it into a well-differentiated group, which we call neuroendocrine tumors, and a poorly differentiated group, which we define as neuroendocrine carcinomas. In that well-differentiated neuroendocrine tumors, we divide them into grades based on the Ki-67, which is a proliferation index. And recently in 2017, this was redone, this classification system, and a new grade of grade 3 or high grade well-differentiated neuroendocrine tumors was described. What was challenging is we knew these tumors are growing at a much faster rate than the traditional small bowel tumors, much like in the NETTER-1 trial. These patients were actually have a higher growth rate, but we didn't know what the right treatment was for these patients, and we didn't actually have any randomized trials for these patients. So this was the NETTER-2 trial. It was an international trial that enrolled over 226 patients. It involved SSTR positive. So again, a key point of this is you have to have the receptor if you want to use the treatment. So we really wanted to ensure we had the right patients. So we were very strict on having SSTR positivity on this trial. They were well differentiated, but had a higher grade. So a Ki-67 of 10 to 55%. So they were on the higher half of the G2s and the G3s. And they really had to have no meaningful treatment prior to entry. They were then randomized in a 2-to-1 fashion to receive lutetium dotatate plus octreotide versus the standard arm, which was the same standard arm as in the NETTER-1 trial, which was high-dose octreotide alone. There is also a retreatment arm, etc. I'm not going to talk about that today, but the primary endpoint was progression-free survival, as it is in almost all neuroendocrine trials. The treatment arms are fairly well balanced. I will mention it was an international trial, so we did have diversity, which is very important. There were slightly more males than females. If you see the composition of the tumor characteristics, we will see that most of the patients had pancreatic neuroendocrine tumor, which it's not surprising given we know the more aggressive nature of these tumors. This is the type of tumor that Steve Jobs unfortunately passed away from, Aretha Franklin. These pancreatic neuroendocrine tumors can be a bit more aggressive. Not surprisingly, given the aggressive nature of this tumor, we saw that almost everybody had liver disease, but there was also a fair amount of bone disease and peritoneal involvement. The breakdown of grade 2 to grade 3 was approximately 2-to-1, with a median Ki-67 index of 17 and 16% respectively. Now, as opposed to normal systemic therapy, we talk about dose intensity. It's hard to do that here because we don't reduce the dose of the radioactivity. We either give the dose or we don't, at least when it comes to this. Now, there are dosimetry studies, but those are separate from this. So we look at the number of cycles that can be delivered. And in this case, 88% received all 4 cycles of treatment. So generally a well-tolerated treatment. And this was the endpoint. You can see here that the progression-free survival improved from 8.5 months in the high-dose octreotide arm. That was very similar to the control arm in the NETTER-1 trial, to 22.8 months in the lutetium dotatate arm. And that, again, was a hazard ratio of 0.276, or a 72% reduction in the risk of disease progression or death. So again, we are having a treatment here that this time in first-line therapy is very effective at stopping progression or death of patients who have more advanced aggressive neuroendocrine cancers. One of the nice surprises of this trial was the high response rate. As I mentioned to you, we haven't seen high response rates in neuroendocrine trials previously. This was different. So this was one of the first trials to show a high response rate. Here we show an overall response rate of 43%. Again, this is independent of the control arm. It shows the activity of lutetium dotatate, or PRRT, in this situation, and it opens the door to potentially further treatment down the road, but also a number of new options that we may consider for radioligand therapy. When we looked at safety, as I mentioned, nausea is an issue when we looked at some of the common toxicities. Diarrhea, abdominal pain was actually higher in the standard arm of high-dose octreotide. But the common grade 3-4 toxicities we want to monitor, as I mentioned, the biggest one is a secondary hematological malignancies. We do know that some of these patients can get MDS, and of those patients, we want to be very cautious in the risk-benefit analysis. At the time of the primary analysis, now we presented this at GI ASCO at an oral plenary in beginning of 2024. At that time, there was one case of secondary malignancies. As of now, we have 4. So we are looking at a rate of somewhere between 1 to 2% in terms of MDS on this. And this is something we're going to have to continue to follow when we think about first-line therapy with this treatment. The other thing to mention is there was some cases of small intestine obstruction. Those are primarily in patients who had a high mesenteric load of disease. And again, one of the areas that we still don't fully understand is has a high response rate. So instinctively, we want to treat patients who have mesenteric disease, peritoneal disease with this tumor and shrink it down. And there's still rationale for doing that. But at the same time, we know that the inflammation that the radiation can occur can potentially lead to a tumor perforation or other complications like obstruction. So we want to be careful about that. There is some thought that giving pre-treatment steroids can be beneficial, but whether that's actually the case, and there's still the data remains to be collected for that to really understand the role of steroids pre-treatment. Now, there was a lot of debate about this in terms of the results, if this is really more aligned with the grade 2s, the grade 3s, the pancreas, the small bowels, as this was somewhat of a heterogeneous population in this trial. So we decided to do a multivariate analysis, and we presented this last year at the ESMO GI conference, another oral presentation. And the results actually indicated in this multivariate analysis that, in fact, the role and the benefit that we were seeing from lutetium dotatate was prevalent not only in the grade 2s, but in the grade 3s as well. So throughout the aggressivity, the spectrum of aggressiveness, we were seeing a very consistent benefit in terms of first-line radioligand therapy with lutetium dotatate in this situation. When we looked at the small bowel and the pancreas, again, right across, the magnitude of benefit was fairly consistent. And then when we looked at the response rate, again, fairly consistent in the grade 2s, grade 3s. In the pancreas, you can see here we had a 51% response rate. It was slightly smaller in the small intestine group, although you will recall in the small intestine group in the NETTER-1 trial, it was 18%. Here it's 26%, given to the fact that this is a more aggressive population. But we generally know that the small intestine neuroendocrine tumors grow a bit slower and are not as fast-growing or aggressive as the pancreatic neuroendocrine tumors. So again, based on this, we have promising results in the use of lutetium dotatate, both after progression in GI neuroendocrine tumors, but also for the more aggressive neuroendocrine tumors in first-line therapy. Now, as of now, there's only one product on market, Lutathera, that's one lutetium dotatate, but that will change hopefully soon because only a few weeks ago at the European Neuroendocrine Tumor Society, we got the results of another trial looking again at patients who had a lower grade neuroendocrine tumors, the grade 1 and grade 2, with another 177 lutetium dotatate or a beta PRRT, but with a different compound, a different chelator. So this is lutetium editotriotate, sorry. And this was compared as opposed to high-dose octreotide to everolimus, which is another drug that we know is effective in this treatment population. So the COMPETE trial, which unfortunately we did not participate in Canada, was a prospective randomized controlled trial, multi-center phase 3. It looked at patients who had a grade 1 or grade 2 neuroendocrine tumor that was unresectable. They did have a small portion that were actually treatment naive, but most of them had progressed under therapy. So most of this was progressive patient population. They were then randomized in a 2-to-1 fashion to receive this new agent with 177 lutetium enetotrietate versus everolimus. The difference here, it's a 4-cycle treatment again. The difference here is that this drug is given every 3 months rather than every 6 to 8 weeks, like Lutathera. Now, again, this was a fixed dose trial. There was no dosimetry involved, but the endpoint remained PFS with secondary endpoints, including overall response rate. The baseline characteristics, as I said, mostly grade 2, but there was about a quarter of the patients had grade 1 disease. There was a fairly even mix between small bowel and pancreas. What's interesting is that there was about 15% in each arm that were actually treatment naive. So the results are a little bit hard to interpret because of the bringing together of both treatment naive as well as pre-treated patients. This was a primary endpoint, however. This was assessed by blinded review, and it was the progression-free survival. We saw a very similar result in about 23.9 months with this agent versus 14.1 months in everolimus. That was a bit higher than the results I showed you, which were about 9 months in NETTER-1 and NETTER-2. Reason being, everolimus is a slightly more active agent in these tumors, and so it's not surprising to see a slightly longer PFS. Nonetheless, here you're seeing a hazard ratio of 0.67. So again, confirming what I would say the benefit of radioligand therapy, and in this case, 177 lutetium, whether it be Lutathera or the new agent in patients who've had some progression. Now, of course, we want to follow up, as I mentioned, closely on the safety data. That really isn't available yet. The safety data that they shared with us at the oral presentation was still fairly generic. So we'll wait very closely for closer safety data for us to understand where exactly we are going to see benefit. Another trial we got an update on, and I actually presented last year when we talked about this topic at Rounds, was the oculorandom trial. Now, most of the trials I've been showing you have been either small bowel or mixed small bowel and pancreas, sometimes rectum. This was the first trial that looked specifically at pancreas neuroendocrine tumors, and it was done by the French group. It was a fairly small trial that I think it was 80 patients or so that had pancreatic neuroendocrine tumors, and they were then randomized in a 1-to-1 fashion to lutetium octreotate or dotatate versus sunitinib, a VEGF inhibitor. Now, these patients were pre-treated patients, and because this was a small trial, the endpoint here was something that we normally wouldn't see, which was progression at 12 months. They already presented the primary endpoint results in the previous year, and they basically showed an 80-20 split in terms of progression at 12 months, therefore calling this a positive trial and concluding that this treatment was promising. This year, just a few weeks ago, we got the updated PFS results. Now, I got to be careful here because this is a non-comparative trial. The numbers were too small to be designed as a comparative trial for PFS. But nonetheless, we see, again, consistent results of a PSF at 20.7 months, slightly lower than what we've seen before. And that likely has to do with the fact that these are more pancreas patients, which can be a bit more aggressive, versus about 11 months in the sunitinib arm. So again, we're seeing fairly consistent results. There's no hazard ratio reported here because, as I said, this was a non-comparative trial. But again, this gives validity to some of the other results we're seeing because the numbers are fairly consistent. In terms of adverse events, they really haven't reported the detailed adverse events we want. We knew that there was some blood toxicity, grade 3, 4. We don't know what they are. I'm hoping in the publication that this will become more apparent because I think whenever we think about radioligand therapy, we want to look closely at the MDS rate and the hematological toxicity versus the clinical benefit. I would say in the trials I've shown you, hopefully I've shown significant clinical benefit for our patients, which is important. Now, what else is coming on the horizon in terms of radioligand therapy? So what I've shown you so far has all been 177 lutetium-based therapy, albeit with different chelators, but 2 different types of what we would call heavier beta isotopes. We are also seeing emergence of a number of alpha isotopes. And in fact, in the larger world of RLT beyond neuroendocrine tumors, I think there's a huge amount of excitement in this. There's a fair amount. There's multiple types of alpha. Primarily what we are seeing right now in the neuroendocrine world is two types. One is actinium-225, and the other is this, lead-212. So this was a trial that was presented at ASCO last year by Dr. Strasberg from the Tampa Moffitt Cancer Center, where they looked at this new alpha agent, lead-212, for patients who had gastroenteropancreatic neuroendocrine tumors. Again, they mixed the patients up, and these are very early results. They mixed patients who were both treatment naive, which was this alpha medix 2, 36. And then they had some patients who were pre-treated. There was 40 patients that were pre-treated. They reported on the first 8 at this time of this readout, and they showed extremely high response rates. So, you're looking at response rates well over 50%, even pooled here. Now, in the treatment naive patients, that is a very high response rate, but even in treatment, only 8. But even patients who have been pre-treated, this is also a very high response rate. So this is a promising agent. I'm going to talk to you about the phase 3 trial that's being developed right now to help take a look at this. But what's interesting in some of this is some of the first data we're seeing in alpha agents is the toxicity profile. Again, this is a bit too early for us to know the MDS rate right now. But what was interesting, there was 2 areas where we saw new toxicity that we hadn't really seen in the beta RLT. One of that was alopecia. We do know that there's SSTR receptors in hair follicles, but we haven't seen hair loss as a significant safety issue or toxicity criteria in the lutetium trials to date. And this was the case in the lead trial. And this actually seems to be only lead. It doesn't seem to be as affected in actinium, which is another alpha. The other area of toxicity, which is still being investigated, is a fair amount of achalasia. And in fact, some of the patients actually required manometry studies and actually required intervention. And we don't have a working pathophysiology right now of why that is. So I think that's going to be important information to try to understand. So as we move forward in this larger world of RLT, whether it be a neuroendocrine, prostate, and the breast, lung, HCC, glioblastoma, the areas to come, I think understanding the toxicity and understanding the disease-specific and isotope-specific toxicity is going to be very important. It's not going to be a case here where platinum toxicity is platinum toxicity. I think here we're going to have to individualize our understanding of toxicity to a much more granular level than we have before. So that really is where we are today in terms of GI neuroendocrine tumors. Currently, throughout Canada, we have 17 centers giving radioligand therapy. We have 5 centers in Ontario, which were one of them, Sunnybrook, PMH. Hamilton is hopefully starting again. They did give it and it stopped. London and Ottawa has a new program. I'm part of, and so is Amit Sugekar, our nuclear medicine doctors. We're both part of CCO's new RLT provincial-wide committee, and they're looking at ways of expanding capacity and starting to think about how we might be able to offer, because I think one of the concerns is, this is just neuroendocrine cancer, but as we start with Pluvicto and we start with other treatments, we are really going to have to think carefully about capacity and what that means and how do we deliver this treatment to patients, knowing that there's certain uniquenesses that we have to be aware of. And then about the lung. So lung is the other big area of neuroendocrine cancers. And where are we at with lung neuroendocrine tumors? Now, right now, we don't have any data that PRRT is an effective treatment in lung neuroendocrine tumors, and we just use it on a compassionate release model ad hoc. But there are 2 trials that will hopefully give us the answer. The first is an alliance trial run through the NCTN, through the NET task force. Unfortunately, although I'm the NET task force chair, we weren't able to open this trial in Canada, primarily due to some funding issues. But maybe this may be an opportunity in the future for us. It's a randomized phase 2 looking at 188 patients who have advanced bronchial NETs that are SSTR positive. They were then randomized to receive lutetium dotatate versus everolimus. And this trial is going on right now. It is having some problems with accrual, primarily in the United States. And a big reason for that is, we know that only about 40% of the bronchial NETs are SSTR positive. So that makes it a bit more challenging as opposed to the GI neuroendocrine tumors, which have a much higher rate of SSTR positivity. Again, recalling that if you don't have SSTR positivity and on the tumor, it really is futile to be treating with the radioligand therapy, because you're not, even though you're going to have this radiation, it's not going to have anywhere to land and is simply going to get excreted. So hopefully this trial will be able to be completed and will give us some information. And then in Europe, we have this run by our friends at Vall d'Hebron in Barcelona. They have a very active neuroendocrine clinical trial program there. And they're looking at this study. It's a pulmonary net study, looking at, again, lutetium edetrotriotide, the new agent that I described to you, 6 cycles versus everolimus, which is the only approved agent that we have currently for lung neuroendocrine tumors, in a 3-to-2 randomization, and they're looking at 120 patients. This trial is actually, because of the volume, is accruing better, and so I think between the two, hopefully we'll have an answer for some years to come when it comes to lung neuroendocrine tumors. Well, that's where we are currently with our clinical data. I just want to touch a little bit about toxicity because we've talked a little bit about why toxicity is important, how toxicity is unique. And of course, the biggest toxicity that we want to be aware of is the myelodysplastic syndrome. Now, this is an uncommon toxicity, but when it does happen, it can obviously have profound effects. So this was a review that was done of all the neuroendocrine trials so far with radioligand therapy, including the single arm, phase 1s, phase 2s that I haven't described here. And they showed from the systematic review that there was a 2.61 rate of patients develop a myeloid neoplasm. So we need to take a pause and reflect on this for a couple of reasons. One is this includes patients who were pre-treated and treatment naive, et cetera, so a bit of a mixed population. So whenever we think of patients developing a myeloid neoplasm, we want to think about the duration of survival and what are we actually inducing more harm than good? And in this situation, I think it's very patient specific. When we are thinking about first-line therapy, we want to be very careful that we are monitoring closely for myelodysplastic syndrome. At the same time, recognizing that when we have a cancer that's progressing, we don't want to hold back on our best treatment. If this is if we're starting on the Stanley Cup final, game 1, we're not going to hold back our best player. We're going to be able to. We're going to want to use that best player right at the beginning to get the best response we can. We do know that when we give systemic therapies, we cause DNA damage. We can also cause myelodysplasia, and that does happen and many times. The difference is that some of these neuroendocrine cancer patients, their survival is longer. So the DNA damage has a chance to manifest itself, where in many, for example, pancreatic adenocarcinoma, even if we are treating with an intense treatment like FOLFIRINOX, intense chemotherapy causing a lot of DNA damage, we don't have the time period for patients to develop the manifestations of that DNA damage. And there's been numerous studies around that. The other thing that's important when it comes to toxicity is sequencing. We're getting more and more data that the sequencing of treatment matters, and potentially using alkylating agents, which we do in neuroendocrine tumors with temozolomide, and if they're given back-to-back with radiation without giving some chance of a bone marrow recovery, we may actually have higher rates of MDS. And that is probably reflected in a slightly higher rate of a systemic review than what we've seen in clinical trials, where it's generally between 1% to 2%. The other big area has been the kidneys, and I think hopefully with the studies we've done so far, we have shown that patients who have good baseline kidney function, which I think is very important, with proper amino acid protection, there seems to be very little damage to the kidneys. When we look at the other hematological toxicity, we know that patients do get hematological toxicity with this radioisotope treatment. This was a large series by Dr. Brabander as well, out of the Netherlands, who looked at, and I don't remember, I think it was something over 500 patients. Yeah, sorry, 582 patients who had toxicity, and showed that over 3/4 normalized after 3 months. So we do see hematological toxicity, but much like systemic therapy, it does seem to recover in most of the cases. The other thing to specific to RLT, as I mentioned, is we got to think carefully about peritoneal and mesenteric disease. I don't think we know the right answer yet. We do know that there is probably a higher risk of bowel obstruction as well as perforation in patients who have a large mesenteric load. At the same time, we know that these treatments have high response rates. And in these patients where if we have bad mesenteric disease and they start getting bowel ischemia, this may be our only option when we've exhausted surgical and bypass techniques. So again, this is a very difficult clinical scenario, and I think hopefully we'll have more information about this in the years to come. So as we move to the future, what can we do in general to make radioligand better? And I guess part of that I would also challenge, do we need to make radioligand therapy better? Well, of course, we want to continue moving forward and maybe increase the response rates and improve survival. But there's a number of ways to look at that. But again, we're going to balance this against toxicity. There have been combination therapies that have looked at both radiosensitizers and dual combinations with chemotherapy in Australia. Our Australian colleagues have done a large trial called the Control Net, where they did show that by adding chemotherapy to PRRT, you were able to improve response and improve progression-free survival. But at the same time, you added a decent amount of toxicity, both hematological and non-hematological toxicity. So again, probably something we won't be pursuing too aggressively, but there are other types of combination therapy, such as PARP inhibitors, which are showing promise, which may potentially don't increase the DNA damage that we're seeing. So we'll have to follow that closely. Also understanding what the role of somatostatin analogs is. What we call somatostatin analogs is cold, the cold SSTR blockers versus the hot, which is the PRRT, the hot agglutinins. So, what's the right combination? How do we combine them correctly? Is turning off the receptors with the hot beneficial? And does that allow is turning off the receptors with the cold beneficial by allowing more of the hot treatment to go to the more aggressive disease? Again, this is all stuff that we are going to continue to be working forward to. There is the alpha emitters, which we talked about, are actually a very promising piece, and probably the future lines of PRRT or radioligand therapy will be through alpha emitters. We have SSTR antagonists being given with radiation attached to them, and in fact, there's a phase 1 trial that's starting very shortly on that. And then the idea of dosimetry is very controversial. Right now, the doses that are based on RLT are based on extrapolation from external beam radiotherapy. And there are new data coming forward with a dosimetry, looking at individualized treatment based on the amount of receptors you have, based on the uptake you have. Now, two things to keep in mind here. One is, toxicity. We may be able to deliver more dose to the tumor, but is that necessarily okay in terms of the dose that gets delivered to the healthy tissue, whether it be through scatter or through excretion? And the second is the simple practical things about dosimetry. Dosimetry is fairly labor intensive. It requires a large amount of work, and we need to understand, in fact, whether we are able, even if there is a benefit to dosimetry, if it's a small benefit, if we're able to find the resources to be able to do that. Then the other piece that we probably are concentrating on, especially here, would be looking at dual PET imaging to try to understand if we can have better patient selection about who's appropriate for radioligand therapy and who isn't. This is some work done by David Chan, who some of you may remember was one of our fellows here, and has now gone back to Sydney to open up his own neuroendocrine program. And he's really been leading the global charge on understanding how we interpret FDG versus dotatate scans. And this was a great piece of work he did from retrospective in multiple center retrospective series that looked at differences between tumor discordant volume between the two types of PET scans, the total number of discordant lesions between the two types of PET scans, and actually the number of intrahepatic lesions that were discordant between the two PET scans, showing a big difference in terms of overall survival. And in fact, right now, as we speak, there is a number of prospective series being done to look at this. So I do think this is going to play an important role going forward. Other areas we're going to look for there's a number of algorithms now that are validating tumor scores, so we can understand who are the right patients to receive radioligand therapy, understanding some of the higher risks, but also the cost, and who are the patients who can get more conventional therapy. There's a few genetic markers as well that are showing early promise in being able to identify those patients that would respond to radioligand therapy. Issues on the horizon, as we're starting to see these higher response rates, we are opening the idea that maybe there is a role for neoadjuvant therapy and we can do more surgical debulking. As I mentioned, combination therapy continues to be an area of interest when we think about chemotherapy, targeted therapies, PARP inhibitors. But again, we're balancing that against how much clinical benefit we're getting by combining therapy versus the toxicity. Intra-arterial administration may be interesting, as well as the SSTR antagonist. And then there's this big push towards alpha agents versus the traditional beta agents. And the two leading ones we're seeing, at least in the world of neuroendocrine, are actinium-225 and lead-212. So to finish up, I just wanted to talk a little bit about our clinical trials program. We have one of the largest clinical trials program in neuroendocrine cancers in North America, and specifically in RLT, we're really increasing our footprint. As I mentioned to you, for NETTER-2, we were the global lead and global recruiter lead, and we had both myself and Dr. Meyerhog lead the Lancet paper on that. Right now, one of the areas we're trying to lead on is looking at retreatment. So as opposed to some of the other therapies which we treat to progression, in most of our systemic therapies, we're going to treat until the disease progresses. With RLT, it's a fixed dose. You get 4 doses and then you're done. And then you have, hopefully some shrinkage and then stable disease. Now, does that mean that we can give more? We don't know. Should we be giving more? Is more better? So we have 2 trials that we're doing. One is led by us, and that is through the CCTG. As I mentioned, we have leadership at the NET Task Force, including me as the chair. And so we were able to lead this trial through the NCTN network. And this is quite significant because it's the first time in GI oncology that a Canadian group has led an NCI study through the intercooperative group. And so we're able to do that now in partnership with SWOG. We're running this trial called the NET Retreats trial, which is a randomized phase 2 trial of lutetium dotatate retreatment versus everolimus in mid-gut neuroendocrine tumors. And that trial is currently underway right now here at Sunnybrook in multiple centers throughout Canada and the United States. And the other big retreatment trial, which we're part of and co-chair, is this. It's a trial called Action 1, which looks at beta versus alpha isotopes. This isn't a head-to-head comparison, but is one of the first actinium trials that's going to report looking at alpha radiation with actinium. As we know, of course, the alpha radiation is lighter. It can cause double-stranded DNA breaks. Due to the less amount of scatter than we see with the beta, there is hopefully less healthy tissue damage through the delivery of this treatment. So this has a lot of promise. This trial is in the midst of being recruited right now. It's over half done. This looks at a phase 3 trial of this new agent called RAISE-101, which is actinium-225 versus an investigator's choice of everolimus, sunitinib, or high-dose octreotide. In the first trial, the NET Retreat trial, we're looking for 12 months of stability after after treatment with PRRT. So I would call that trial durable responders or good responders. These patients have had treatment and then have 12 months of at least stability, if not more. In this trial, they're looking for patients who have had at least 6 months of stability. And to me, that would be not treatment resistant. So we're kind of looking at 2 different patient populations. One's a durable response, and one is in this patient population is ones of patients that are not treatment resistant. The other controversies are, do we continue the SSAs? As I mentioned, the relationship between the cold and the hot agglutinins is still to be understood. This is a trial that's being done in collaboration with our Australian colleagues. This is through the ComNets collaborative that we have developed with our Australian and New Zealand colleagues in neuroendocrine cancer. It's a very small trial funded by a CHR grant, but it's the beginning of looking at what role the cold agglutinins or somatostatin analogs would be looking at in terms of post-PRRT, and we have this open right now as well. Finally, we have a few trials that we're in the work of opening right now that will be open hopefully in the fall or early next year. The big one is the NETTER-3 clinical trial. So this follows on the NETTER-1 and NETTER-2. And again, we've been fortunate enough to be asked to be a global lead in this. This study is going to look at the unanswered question of the early grade neuroendocrine tumors, the G1 and G2, with a high burden of disease, a lot of liver disease, bulky lymph nodes, a fair amount of peritoneal disease, and try to understand if by giving RLT up front, we are actually benefiting patients versus our standard treatment, which is somatostatin analogs. The primary endpoint will be progression-free survival, although we will be looking very closely, obviously, at the safety and tolerability as we move this treatment up and up on the treatment armamentarium. Another actinium trial that we're hoping to do in first line is run by a Canadian company called Alpha 9. We're doing this trial in partnership with the BCCA. And it looks at actinium-based therapy with a separate chelator that's given from before, hoping that this will increase the binding specificity of the compound to the tumor. So that's very interesting. It's going to start with a phase 1B trial, and this is actually going to be run through our phase 1 program here, which is very exciting. It's our a growth of phase 1 in RLT. There's actually 3 cohorts: a neuroendocrine cohort, a breast cancer cohort, as well as a lung cancer cohort, and we hope that we'll be able to give a significant contribution there for the phase 1. And that is the plan. Is once the phase 1 dose optimization is done, it'll roll out to a full phase 3 globally. Finally, the last trial that's going to be of interest is the first trial that's looking head-to-head alpha versus beta. This is a really big trial. This is run by AlphaMedix, which is the company I showed you before that did the lead. They've now been bought or in partnership with Sanofi. Almost all the major pharmaceuticals now have an RLT branch. And this is based on their phase 1 results. The schema is still being finalized, although we've been chosen as a site, and we will hopefully be one of the leading sites looking at head-to-head of lead-based therapy versus lutetium. So with that, hope I'll conclude, and we have some time for questions. Really exciting times in the role of RLT, both in terms of new treatments, improving the care of our patients, and moving things forward. At the same time, we're monitoring things like toxicity, feasibility, and the resources to be able to deliver these therapies, and trying to understand where it best belongs. I would think of neuroendocrine as a test case. We're starting to see what happens in neuroendocrine be reproduced in prostate. As I mentioned, it's now in breast. There's colon cancer trials being open. We have glioblastoma trials, HCC trials. So RLT is really something new. It's going to be like the new immunotherapy. So I think it's important that we're all aware, and at least we have some understanding of where we're headed. And we've been very fortunate in neuroendocrine to sort of be the bouncing pad for this into the general oncology world. So I'll stop there, and if there's any questions, happy to answer them. You can put them in the chat if anybody has, or Urban has a chat. Any role for antibody-drug conjugates in NET? So yes, there is an antibody-drug conjugate targeting SSTR2. If for neuroendocrine, there isn't any other targets than SSTR2 for neuroendocrine, but for, as you were aware, in prostate PSMA, but looking at FAPI and there's many other targets that are being identified. The fortunate part about neuroendocrine cancers is the prevalence of SSTR receptors are fairly common, especially in the GI neuroendocrine tumors, not so much in the lung, but even in that, it's almost 50%. But in other tumor types, it's not as easy to find the receptor in terms of the target. And I think that's the real challenge as we move forward in RLT is, the isotopes are there, the chelators are there. Sure, we can improve them, but really it's finding the right target to be expressed, the receptor in the cells, so that you can give this with some sort of confidence of efficacy. Any other questions, comments? Happy to hear anytime anybody, if any has any comments or questions. We're really excited about the trials we're opening. Rosanna's opening the phase 1 trial, so that's again looking at multiple different tumor sites, and this is really an area of growth that we all have a great opportunity to be involved in at Sunnybrook. So very exciting times. Sorry, question from Paul. While waiting for the LungNet trials, what kind of access do we have to the API? It's a very good question. We do have access in terms of compassionate use. The question is just showing that there is SSTR positivity, which can sometimes be challenging because generally when we get to that point where we're starting to think of PRRT, it's in those patients who've had either dedifferentiation or have aggressive treatment, and they start to lose their SSTR2 positivity. But we have treated some patients here. It is inconsistent, as you said, but hopefully as we continue to grow and we start to think of these tumors, the tumor site is one area that we can classify them by. But in addition to that, I think we're going to probably think about a rubric, so like SSTR2 positivity, and SSTR2 positivity is important. So I wouldn't hesitate if you have a patient, I'm happy to discuss anytime, but if you have a patient who is SSTR2 positive and there aren't other options, I do think we probably want to start thinking about what our role could be of PRRT, and maybe we want to start collecting evidence ourselves. Okay, if there's no other questions, thanks so much for attending, and please feel free to reach out with any questions anytime with email. Thank you.